So today I want to give you a talk about agency, and if you feel you need to interrupt, please do. I won't be upset if you do. I'm trying to get about 20 minutes at the end for question time. And so it's really important that if you're feeling lost, do ask questions, because I can modify this talk in a lot of ways. It can go anywhere from 30 minutes to about 2 hours. So I'd like to acknowledge the traditional owners too and pay my respects to elders past, present and emerging. And it's really important to acknowledge that one of the key things around agency is around learning and transfer of information. And that dates back to the earliest hominoids that have walked the earth. And our Indigenous people, one of the few groups that had linkage all the way back for 60,000 years. And I hope that through preservation of their language, we will actually be able to translate some of that into better ways of thinking about how we deliver healthcare. So a little bit about me. I have a very unusual background. I trained as a physicist, fell in love with genetics. I did a master's in genetics, got disenfranchised with science. I left science and did what all young boys do. I went away and joined Special Forces. Context is everything. So in Special Forces, I was reasonably outspoken about systems that didn't work and was eventually sent off to Duntroon and got a commission, picked up a computer science degree. Well, I built these really cool technologies that allowed people, commanders, to communicate from their computer desk with Special Forces in the field anywhere in the world. And people thought this was really good. However, what it did is it changed organisational behaviour. So instead of the commanders sending out succinct messages, they would write essays. And the signallers in the field would have a one-line LED to take down the information and then have to decode it. So instead of getting a succinct half-page message, they would get 10 pages. What also happened was I automated the job of 2 of my sergeants, whose job was to check the messages being sent, and if they were too long, they'd go back to the bosses and say, sorry, sir, you can't send this, you have to shorten it. Well, those 2 sergeants left because the most interesting part of their work was automated. And the next year we had sunspots, which meant you needed advanced antenna theory to be able to communicate. And my 2 sergeants with that skill and myself were the only people. And so for that year on a major exercise, I worked 22 hours a day, filling the gaps that I had created by introducing a technology to automate things. So if we don't think about automation in terms of systems and what are the upstream and downstream effects, we can get it really, really wrong. So I did my PhD in anaesthetics, looking at anaesthetic displays and designing those to inform clinicians, and I got something wrong there. I made it such that there was no money in it. So industry wasn't interested in putting them in until the patents have expired. So they're now looking at it now that the patents have expired. So some of the things I also will cover will be thinking about how you think through and implement things successfully. So I've done a lot of work in healthcare for the last 20 years, anaesthetic displays. I've done work in defence, intelligence systems, command and control, submarine visualisation systems to allow commanders to think differently, power industry to allow Starry Mountain engineers to be commercial entities as well as engineers that look after safety. So it's a very diverse background, but the important thing throughout this has been thinking about agency, how people work together and how technology as an agent works for people. So I'm just going to get you to think a little bit and think about how you make decisions. And what we tend to get is something like this. So this is an insulin chart developed by myself and my team, where we were looking at the processes for how you manage hypo and hyperglycemic activities. And these are the rule structures that we came up with. It only took 2.5 years. So we interviewed experts on what they did. We observed experts on what they did, hundreds of hours. We created the design. We then put it out for 6-month testing in private and public. And then we came back and redesigned it. And we did it again for 6 months and redesigned it, because what people do is very different to what they think they do. So work as done is very different to work as imagined or work as prescribed. So they started telling us about work as prescribed. And after the first iteration, we moved on to how they imagined they were actually doing their work. And we finally got toward optimization. And none of our experts actually followed this, but this was more efficient than any of our experts. And so that ability to use multiple design processes is absolutely critical to understand thinking, because thinking is actually far more complex than a flowchart. That's a psychological visualization of it. It's not how we think. So actually how we think is very, very different. Most of our decisions are intuitive. They're based on prior experience. It's subconscious. We react to it. We have spontaneous decisions where particular things prime us and we respond rapidly to those. And when you look at any decision model, you will not see either of these two included in them. Avoidance is another one we do. Very, very common in clinical. And there can be very good reasons for it. So it's not a bad decision model. It can mean we don't have enough information. Now, this is where we tend to focus on rational, differential diagnosis, logical sequences, flow charts. That's where we want things, the engineered model of how we think. And yet it makes up very little of our decision making. So very few decision making in healthcare would be huge, 100% rational. And then we have the dependent decision making, which requires some form of consultation. So again, when we interview people, we're not looking at that process. So we tend to build it around a single person's mental model, not the actual process that goes on in healthcare. And those processes are really important because they form the basis of our education. They form the basis of our collaboration. They underpin major systems things. So it's really important to understand that we have multiple ways of making decisions. So how do we imagine decisions made in healthcare? And so I asked AI to give me some images on this. And here it is. This was its first go. Patient and clinician happily discussing things. Then I suggested that maybe the family and there'll be multiple clinicians involved. And this was the model it came up with. And then I said, what about the technology? So it threw some technology in. And I said, what about the systems of decision making across all of healthcare, including, and I listed all the different roles. Sorry, that's what it came up with. And that's probably the closest to it. So the pathologist acts as an agent for the clinician when they do studies and send you the results of those studies. You don't question how well they did the study, you just look at the result, and they may give you some interpretation with that result. But you're assuming they're following a rule-based process. And when I've gone into pathology, it turns out they sort of do. They're better at it than other parts of healthcare, but they're not actual perfections about it. Sometimes they don't have enough quantities. Sometimes they're competing between different tasks and forgotten their timing and it's not quite precise. But the results you get don't have that annotated on what could be wrong with those results. So decision-making is a series of asynchronous decision-making, and it's managed disparately across multiple teams. And it's really important to recognize this if you want to get into computer-based agency, because we tend to only focus on who's tapping into the screen, not what are the upstream, downstream effects. And in fact, the decision-making should be central around the patient, the family, extending to the clinicians, but it does include the healthcare executives and, in fact, the governance. So sometimes your hands are tied about what you can do. And my own children, I left work for 7 years to sort out my own children's health because we're in a healthcare system unable to deal with it. They're a very rare group of kids, and that makes it really hard for a healthcare system that's trying for optimization. So we need to think about how are we dealing with individual decision-making, delegation of decision-making. So a consultant may still be the responsible person when a registrar has made the decision. And that's really important to capture in your models to think about. Consultative. So most consultative decisions are not captured on paper or in electronic records. When someone asks another team member a question or picks up the phone and calls another consultant, there's a small chance they'll enter it in the records, but most of the time it's not all entered. And then we have the concept of escalating. So when we're handing over decisions and about what's happening there, is this an escalated decision? Has some decision making by the nurse already gone on before the doctor is looking at it? And before the registrar responds, or the consultant comes in, who else is being involved in understanding how those decisions formulate outcomes? And then finally, the least used, is structured group, but it's the most common in terms of distributed group decision making. So we're not really good at having processes of how we do this, but a lot of things are actually indirectly influenced by group decision making. And so now think about your own healthcare. Who do you want to look after your healthcare? Who do you want to be seeing you? For most people, you want the best expert around your thing, all working collaboratively. That's the model we want. And in fact, it's the model the public thinks they get. From a healthcare point of view, that's the opposite to what we want. We want novices. We want the cheapest people possible. And that's to ensure the future workforce. We want to free up expertise for strategic planning, training and things like that. And we definitely want to reduce cost. So we want novices in healthcare to achieve expert outcomes. And there are potentials to do that. We can train very rapidly. We've demonstrated in driver training, we can give you 1,000 years of driver training in 3 hours. We could do the same in healthcare. But we can also do the same by giving you the right information at the right time, using the advantages of what we can get out of digital systems. So expertise is what we're looking for, and that's how we deal with complexity. And there's lots of studies on complexity. There's not a lot of work that's great on expertise. So lots of people are good at documenting it, but the ability to transfer it's pretty poor. And Gary Klein's work, so I've got a list of references at the end of this, but Gary Klein's a name you need to recognise and learn, because Gary has done an excellent job of understanding how intuitive and structured decision-making goes together and how you can analyse that and expertise and actually transfer it to some other people. So if we're going to build agents, we need to understand how we're going to collect expertise. So what are agents? And this is where I avoid things like AI and machine learning and actually get to the concept of agents. Because most of you will at some point used a travel agent or an app to do travel. You'll have a whole range of people acting as agents for you, bank agents. If you've got a home loan broker, they're an agent for you. We use agency a lot. And it can be humans, it can be technology. So it's a thing or person that does an activity or a process for us. And they're designed to provide decision support. Rarely are they designed to replace decision making. And I think that's very important to understand the difference between those two. So things like the charts, I'm heavily involved in charts, clinical pathways, medications, all these things are a type of agent. They're a very basic procedural-based agent. So I can tell you for the moment, clinical pathways probably help the people they're designed to help and harm people we've got maybe more complex and don't fit the pathways. So they're probably doing no better for us in terms of patient outcomes overall, but maybe doing better financially for organisations. Paper-based charts can be really effective if clinicians follow them. However, compliance is often really, really poor. But we're moving into an era now that we can have software agents. So when I built agents back in, computer agents back in 2000, they required very large servers to do very simple tasks. Now your phone would do everything we could do in the military in 2000 without a problem. So we have the potential of technology to implement really powerful agency. The issue becomes knowing how to do that effectively. So we also need to understand that when we build something, is it acting as an agent or is it acting as part of an agent, collaborating with other agents? And in fact, the more we build, the more likely we have to build this as a network of agents and just think about how agency occurs between multiple humans and multiple computer-based agents. So typically, we're looking for decision support. In healthcare, it's more predictive, it's rule-based. We tend not to use a lot of machine learning. There are strategies. So these are things like the OODA loop, the orientate, observe, orientate, decide, act. We also have things like differential diagnosis. However, I'm very much aware that differential diagnosis is hardly ever used these days by junior clinicians. They do shortcuts all the way. So we've moved away from some of those type of strategic tools. And then decision support tools, which you all use. So the first one you use probably every day is the weather. There's a computer agent that's determining the weather for you, and it's influencing your decisions of the day. But you will use hundreds of decision support tools. If you use an anaesthetic machine, it's got AI in there and has had AI in there for a long time. You probably don't know how it works. In fact, the technician probably doesn't know how it works. Because anaesthetists in the 1990s would know how to pull apart their anaesthetic machine and reassemble it. They wouldn't know how to touch the existing machines, but the existing machines are safer so long as we can wheel in a new one when the one you're using breaks. So we can make systems safe without having to know how the technology works. But they can be used, and it's very important you think about which ones you're wanting to use these for: diagnostic, directive, collaborative, nudges. So the idea is that they remind you to do the right thing. Could this be a sepsis patient? There's a few key things coming up here. Do we want to nudge people to re-question that? And in Queensland, we've introduced a process where you actually have to go, no, I don't think it is. You actually have to actively close it and say, I've made the decision it's not. And what we find is people pay far more attention to the risk of sepsis by forcing them to actually deliberately say, no, this is not sepsis. And then you've got agents that can be used for training and education, so just in time. You've never seen a patient like this before. Let me introduce you to someone who can help you understand this patient. Or, in fact, here's 5 other cases that you can quickly look at beforehand that match the one you're about to do. And then we can use them for feedback on your performance. So unfortunately in healthcare, you get very little feedback as clinicians. So the clinicians who misdiagnosed my daughters, a lot of them don't know they did because we went elsewhere. It was just too hard to go back to them and give feedback. Having to pay $300 to see them again to give feedback is not an incentive for the patient. So agents could be used to provide feedback. And so now we get into the complex stuff. What is the data that the agent uses? And so we could be dealing with human agent or human categorized data. So these are things like a Glasgow Coma Scale, something you observed and decided. It could be about more mobility, it could be their behavior. These are things that you might be good at observing, you might not. And we find that about 30% of the time in clinical records, what was claimed is not actually what's there. So the inaccuracy is quite high. Human measured vital signs. So I've got a couple of systematic reviews, one on respiration, one on blood pressure, and what all the errors that people make, and virtually no entry into a data set is correct. However, the level of error may not be problematic to the outcome measure. And automatic things can measure things incorrectly. So if you put on a pulse oximeter incorrectly, you're going to get the wrong reading, and automatically you'll be registered, and it's very hard to undo that in a system. You can't sit there and say, oh, I put the pulse oximeter on. That's permanently in the patient's record. It's automatically capturing it. Written language is now becoming popular, so we can analyze written language, but there are problems with written language because it changes contextually. So the work I did in 2000 is no longer relevant to nurses now because the language nurses use now is actually different in records. So it's changed in 2 decades quite significantly. You've got spoken language, which can be automatically transcribed, and actually may be a more powerful way to get data. And then we also need to think about temporal information. So when's data collected? Is it at even intervals? Is it at different intervals? And then how is it represented? So we find with deteriorating patients, if data is collected at the right time because of where the patient's vital signs are, it totally changes the outcome to someone who collects data at random intervals. So the predictive rate of change is really important for clinicians to interpret. But if we present you the data in the wrong order, or a different order to what it was gathered, that will change your decision making as well. We've done some studies that show that it's really, really problematic for clinicians. The first bit of data is often the most powerful bit of data that they will pin their decision around. So what do we do? Because computers, see talk in the papers, computers replacing, or AI replacing doctors. And I think we're a long way away from that. AI may dumb down doctors and stop doctors from progressing to advance clinical practice, but AIs may help them to do it at the current standard slightly better. But what they can't do is they don't have the equivalent hearing, vision, smell, or touch that we do. and they're so far away from having that. So they may have cameras that can see things and recognize things in a X-ray that we won't pick up, but they can't see things like a person change in a tremor. And yet we won't know. We won't be able to describe what it is, but a good experienced clinician will know it. Hearing is far more than the words. It's the pitch, it's the cadence, it's the breathiness, it's a whole range of things that AIs are so far away from knowing. And sight, an experienced person will tell skin tone, inconsistencies of movement, especially around breathing. So it's interesting watching young trainees go in with the charts and take the patient's respiration and write down the respiration rate and not know the unevenness of the breath, because they're trained to record the rate, not understand breathing. So one of the downsides of modern charting is actually we're de-skilling things that would have been major things to identify in the 60s. And smell's really important. So people dealing with diabetic foot ulcers can, without knowing it, could tell the severity just on walking into the room. So interestingly, when we introduced this in simulation, it made no difference to the novices except for making them queasy. And the experts tuned it out immediately and then focused on the other visual signs because that's what they could teach the novices. And touch is really important. So when we take a person's pulse, you feel more than if you have something automatically recorded. So we lose information if we just rely on machinery. So we need to understand these things to decide whether we're going to sacrifice them or keep them involved in any type of agency. We all have different ways of dealing with things. So we don't deal with too much data. We're attracted to bizarre, visually dominated things. We draw on details that confirm what we already diagnosed. So if you look at cognitive bias, it's really, really important. Agents' problem is the data set they're trained on is the world. They don't have this concept that there could be more. They don't have doubt. They don't really convey intent, and they definitely don't convey intent plus how long that intention there are. If you look at the beliefs, desires, intention models. So we often want clinicians, doctors to be overconfident because you have to act kind of like a pilot. But we don't want them to be overconfident because they can go around again. We can ground all the planes. We can do things differently. Patients don't have a pause button. So we want a level of confidence that's really important. But in many ways, agency into technology is overconfidence because we don't know what it doesn't describe. It has no knowledge of the unknown. So what's also important to know is what the agent knows and how it works. So if I go back to anaesthetic machines, I have auditory displays that allow clinicians to monitor the patient without any visual displays and know that the patient is properly ventilated. And we were having trouble. We built this on old bellows models, and then when we tried to implement it on the Drager new machines, we couldn't get it to work. And the anaesthetist didn't know, and the technicians didn't know, and we reverse engineered it and eventually contacted the people in Germany and said, "You're not meant to know that, because that's their secret, company secrets, because it's not patentable." So we had to work this out to understand how it worked so that we could design how we would collect a side flow from this to measure things accurately. So if we don't know how a technology works, if it's a completely black box, it really has a negative influence on what we can do. So we need to ask some questions. And looking at the time, I will leave these, you can have the copy of these PowerPoints, but these are the things that you need to ask. And one of my favourite ones is the geographical location of the patient. So coming from Queensland, a colleague of mine on the weekend was running statewide retrieval services. It's impossible from someone who's not used to working across thousands of kilometres to understand that you need to understand the different timings of different assets to move patients. Is that a 3-hour flight? If I use that 3-hour flight, that means I've got one more aeroplane left to use elsewhere. So I'm not just thinking about one patient, I'm thinking about 50 different children and how we're going to manage that. When we design agents, we build them and tend to be around an operating theatre, a ward or something like that. We don't build it around a patient's travel within clinical settings. So these are the general rules I've come up with around decision support system that you need to have before building anything. And I've tried to simplify this. So this has gone from 96 points down to 22, down to 7 over 25 years. So all data sets are subsets of data available, and that includes whether it's humans doing something or a computer element doing something. It is something you need to have mapped. The data sets that require good decision support are dependent upon the quality of the data. So you need to know, for example, in healthcare, we have very poor data in general. So when people are building agents around sepsis, they were surprised that 30% of decisions, clinical diagnoses, are incorrect and not always rectified because the patient goes home well anyway. We estimate that the same would be around vital sign measurements. At least 30% of those are incorrectly entered. So they're close, but they're not accurate. Understanding the timelines of data. So how efficiently is data collected to when it's useful? And the relationship between data and one or more useful categorization. So we may create a new tool that a novice could detect a patient's deterioration with that an expert won't. Because the expert has a mental model that's built on particular things. I can give a novice a tool, a simple flag system that they can follow very easily. So understanding how it is meaningful to people is really important. The ability of people to act on the data set. So if you can't act in a timely manner, you ignore the data set. Doesn't matter how good the display is. So in power systems, we worked out the visualization had to be within seconds. In auditory display, it has to be within hundreds of milliseconds. In patient records, it has to be within hours. So there are different time frames. Now I say within hours, that's the majority of patient record until you hit something like sepsis. And then we need to get down to 10-minute intervals. So you have these different things that are important there. That leads into the next one. Decision support systems don't support everyone equally. So if you design with experts, you're designing for experts. And the most likely people to use a decision support system are novices. So when we design them, we test with psychology students because they're equal brightness to nurses and doctors, but they have no clinical knowledge, no preconceived ideas. So do they produce good outcomes? And so in some cases, I've seen products that actually produce better outcomes with novices than they do with the experts. Because the experts take shortcuts, or in some cases, the experts actually aren't as good as they thought they were because things have moved on and progressed. And it's why things like a lot of the colleges won't let examiners examine after 10 years past their fellowship because they no longer have a broad enough level of expertise to examine the people coming through. It doesn't mean they don't provide anything that's really good. It's just their expertise may be slightly focused on a small, or what we focus on a small area, not the breadth of the whole thing. Cognitive bias is one of the things to really understand. In decision support systems, I can get people to make their own decision 100% of the time. Really, really easy with visualization to do that. I don't have time to give you examples here, but we can reliably do it. So we need to understand the power of our biases and how that works. And to understand and alert people to boundary conditions. When is the system no longer functional? And it was really good on the submarines to do this. So submarine commanders keep 4 mental models in their head concurrently. I've never met any other group that most people can only keep 1. I've met some people who are trained to keep 2. These people can keep 4 mental models concurrently, and they can switch between them using a clock. So for the next minute, I'm going to work on this mental model and just disregard all the others and assume they're rubbish and see if I can prove this mental model. They are very good at actually saying none of my mental models work. I need to start again and go back to raw data and build up another. But that takes a real level of skilling to get there. We had 6 commanders when I did the interviews with them in the whole country. So very limited, highly trained group. When you introduce a decision support, it's also very important to understand it changes the way work is done. And as I gave the example, I convinced my sergeants to quit their work because the really exciting bit about their work I'd taken away from it without even realising that. They didn't even realise it was the exciting bit until I did that. So you need to look at the secondary flow-on effects that you have with decision support systems. So cognitive bias, there's a lot of them. And we've never totally mapped these, but I think whenever you do build a decision support system, you need to be going through and trying to understand these. Some of these we can come up with management techniques around, some we just need to be aware and let people know that the biases will have changed. We all have them all the time. This is probably the best visualization I've seen for it because it groups them into, I think, the four most important groups: too much information, not enough meaning, need to act fast, and what we should remember. And they're really good ways to think about how you're going to manage and think about technology. So our data's got cognitive biases because the people who designed and selected it will have there. We need to understand how cognitive bias will change your choice. So if I tell you a patient has 78% chance they've got sepsis, I can tell you 100% of clinicians will treat them for sepsis, not 78%. Because when they think about going to a court, if they have to defend why they didn't, no one's prepared to go against the probability. Even if they are convinced it's not, they won't because of accountability. So we need to understand where blame is going to be laid when things go wrong. And we're really poor about this. So I've watched digital health systems go in, and I've watched work increase and patient outcomes not improve. That doesn't mean we shouldn't put the digital healthcare systems in, but we need to understand the functionality, the accountability, the skills required. And in some cases, we need to actually say we need to do healthcare very differently if we want to use a digital healthcare system. And that's all right, but you need to go there and you need to understand the blame game. And you need to understand how trust is influenced. So if I give a group of novices a tool that's more likely to be correct than their consultant, they won't trust their consultant for other things that the tool has nothing to do with. So we have to understand how we manage that trust integration there. So trust in our peers, trust in our seniors, but also trust in the agent. If your first experience that the agent is wrong, it's very hard to get you to have the second. If your first experience the agent is right and it's dramatic and it's change, it's really hard for you to doubt the agent. And we did this in the military where we had avatars providing advice to commanders with agents acting behind them. And the commanders did a lot better. And the avatars were just mining the internet for news articles on the training exercise and presenting to them. So I, being devil's advocate, added some false information. And the commanders did poorly and they could still continue to listen to the agent. And then we told the commanders that 20% of the information was false. And they can still continue to listen to the agent. And we dropped it to 50%, and they still continued to listen to the agent. When we asked them afterwards why, they said, well, the agent said so. So they could hold the agent responsible and not themselves. So we need to understand that accountability and trust. Now, if we had started at the 50%, I suspect what we would have seen is very little trust in the agent. But because it started at very high reliable data, they couldn't disassociate even when told that 50% was wrong.
That influences the thing you're talking about to start with the novices. So we often get junior doctors who are going to consultants, and then in presented with information, that contradicts, a plan. They're like, oh no, that's what the consultant said. Yep. They know what they're talking about. And they're like, but I'm giving you this information. I'm going to show you, like, this is why I think it's something different. And they're like too scared to approach them. They won't second guess them.
So that's the blame bit coming in. Yes. Yeah.
Can't blame me. That's what the consultant's written. Thanks for your advice, but no, we're not going to change anything.
So we see this all the time because we don't have, the military has really clear hierarchical accountable structures. So we don't see it there. We don't have that in healthcare. It's a collaboration. Very, very different. And you're looking at, will the consultant pay out on me later because I've undermined them? So you've got a whole range of behavioural things, but it's the same with agency. So we need to think about what roles we done. Who's going to be who's delegating it, the assessment, decision making, the consultation, the escalation, and feedback. So no one seems to be wanting to build AI for feedback to clinicians, but it really is the most important thing we could. On average, how did your patient do given your diagnosis? How do your group of patients do around this? Because if we upskill clinicians, we're in a much safer place, because if someone cyber attacks the system, we still have the clinician. So think very laterally about where you could do things. Now, how to best do it. So this is, again, something's 25 years. You should automate tasks where the agent does it better than humans 100% of the time, or 99.9% of the time. There's a logic to doing it there, but it needs to be so close to 100% before we automate. Because as soon as we automate, we de-skill the humans, and that may stop them progressing to learn about other things. There's collaborative models we can use. So this is about how we keep the human in the loop and thinking about the agent, and nudges and things are really, visualizations are really powerful ways of doing this. So the agent's not going to tell you it's 78% of sepsis. It's going to give you a visualization and show you where this compares with other patients with similar vital signs, similar age group, body mass, all these types of things. Where does your patient sit? Does it sit within the group that got sepsis or outside? And you'll see some will sit with the same vital signs, will still be outside, but you can make a decision more informed that way. But then there's the third model, and this is the learning model, where it's very much about educating you. So instead of saying you've got sepsis, it looks through the hospital, who's free at the moment, who's seen a patient like yours, and calls them, and they come in and work with you through the patient. So suddenly the agent's just finding the clinical skills and the clinical knowledge within the hospital and bringing it to the clinician such that they can learn. So three very different models of where you can apply agency. And what we tend to get focused on, if you get from the engineering side, automation. What does automate it? We'll make it automated, it'll be better. And the reality is that's probably not where we should be focusing. So think very clearly about what of these three models are you trying to do. And in some cases, it may be we're going to automate this bit, we're going to be collaborative on this bit, but I have an opportunity for learning here. And that's really should be our ultimate goal. And the most important person we could help with learning would be the patient. So compliance of patient with medication, compliance with patient with therapy is very low because we're not providing the feedback loops. So again, when you think of agency, you can actually think, how do I take this a step further to the patient as the center of care? And now the most important thing is evaluation. So it's really, really important that we test. I would have come to you 10 years ago telling you about cognitive work analysis, and you must use this method for design, and then a little bit later co-design, and then a little bit later simulation rapid prototyping, and now the only thing I say is you must test it. Test it in simulation, you must test it clinically, have your feedback loops, have your measures, understand whether people are compliant. So if it works really well but no one complies with it, it doesn't matter. You haven't engaged properly. Understand whether it produces side effects. Really important to capture that information. So we can do multiple level testing. We should do it during design. We can do it when implementing, and then we should do it post-implementation. And we've got an example where we implemented a whole range of standardized procedures where we reduced adverse events 100% for 6 months. And then we left it for the next 6 months and no adverse events. And then the next 6 months, we're back to where we were beforehand. And it was a communication strategy. And what had happened is 6 new registrars had come on board and didn't want to do it. Everyone else stopped doing it. So unless you get into the post-organizational looking at that, you're not going to really know if your agency works. And we've got to deal with the regulation. So the TGA is getting better at this, but not great at it. There are lots of things out there that the TGA don't recognise as acting an agency for patients or clinicians, but they are. We need to be able to look at internationally how we benchmark, because we do that around clinical practice, but we need to also make sure we do it around how we bring automation and technology. And again, I'm going to leave these. It's too hard to memorize them all, but they'll be there in the PowerPoint that you can have. this isn't cheap. When we make a pharmaceutical, we're prepared to spend $100 million on it. When we make an IT decision support system, we want to do it for 10,000. And it's just the wrong mental model. If I go to aviation and say, I want you to build a new plane, well, they're not going to do it for $10,000. In fact, probably the best example is the Airbus A380. They were using simulations to design it. The pilots weren't asked what the plane should look like or how it should work. They were asked to fly it in a simulation of a plane that didn't have wings. Literally didn't have wings because they didn't have the metallurgy to be able to produce the wings they knew they needed. But they had the models that predicted within 5 years they would have the metallurgy to do that. So they got the pilots to understand the interface and work with the pilots backwards and forwards to design the interface. But the system was built through simulation with expert groups around the technologies because of the number of black boxes used in the A380. And so it was a whole model of development, whereas we've got the startup model in healthcare of I've got this really good idea and we need to think, how does it plug into the system? So human factors is normally left till last. And it's something I think you need to do at the very beginning. You need to understand your first design's going to be disastrous, the way I always go. Our first design's not going to work, but we're going to implement it to test it, just understand why it doesn't work. Is it an organizational failure? Is it an interface failure? You need to have enough money. So healthcare is now starting to put money into digital health. So you're at the right time being interested in this area. 10 years ago, it really wasn't great. It was how do we turn paper into electronic stuff rather than how do we reconceptualize healthcare. Lots of design approaches there. Most of them have a book or two on them. In fact, some have 10 or 20 books on them. Highly recommend that you go through those, choose one, but come back to the testing. So intellectual property is actually really, really important here. I never used to think so. My first big mistake on intellectual property was I designed a landing display for an auditory display for aircraft so I could go to aviation psychology conference. The supervisor said, if you want to go to the conference, you have to have a full paper. So I designed a display and I went there and presented, and a group from Boeing came up to me and said, we'd like to buy your display. And I said, oh, you can have it. And they said, what, you're going to give us your patents? I said, I haven't got patents. And I said, we'll take you out to lunch and just say what you did because it's never going to be used. Because I disclosed the method of doing it, anyone could use it. Now, it would cost them $40 million to validate this, and Airbus could put it in the day after that Boeing validated. So no one would engage because the intellectual property had no value. So we need to understand this really importantly. And the other bit you need to understand is you're probably going to be using someone else's technology. So Bohemian, who produces simulation equipment that the military use around the world to build all their digital twins, when they had 13 staff, 1.5 of those were lawyers, looking at the licensing agreements they had with other companies. Now they have hundreds of staff, and the lawyers are still at the same ratio. So you really need to understand the technologies you're using. If you don't understand how a third-party agreement changes over time, you may have produced a product that relies on some of theirs that you now no longer can use. So really important. And so at this point, there's a list of references there for you.